Hello, this is an EHAD webinar from the series of rare bleeding disorder. Today, me and my colleague, Dr. Saskia Schols from the Netherlands, will discuss Factor XI deficiency. In this first webinar of RBD addressing Factor XI deficiency, we will address the following topics: epidemiology, genetics, symptoms, bleeding phenotype, diagnosis and treatment of Factor XI deficiency, case report that will be presented by Dr. Saskia Schols, and then the latest major literature reviews. These are our disclosures. Let's start with the introduction to Factor XI deficiency. You can see here the worldwide distribution of rare bleeding disorders derived from the WFH and ENRBD registries. Any disease with a prevalence of less than 1 in 2,000 is referred to as a rare bleeding disorders. Among rare bleeding disorders, the hemophilias are more prevalent. Factor XI deficiency is relatively prevalent among the rest of the rare bleeding disorders, and kindly note that the geographic distribution of rare bleeding disorder is variable, with higher incidences in areas of consanguinity. Factor XI deficiency is a rare autosomal injury-related bleeding disorder with an estimated prevalence of 1 per million among Caucasians. However, you have seen that it is one of the commonest hereditary rare bleeding disorders and accounts for 20 to 30% of RBD patients. A higher prevalence is observed in several ethnic groups due to common founder mutations. The Factor XI gene spans 23 kilobases of the long arm of chromosome 4 and comprises 15 exons. Factor XI arose through a duplication of the gene encoding plasma prekallikrein. It is a homodimer with 2 identical subunits composed of 4 apial and 1 catalytic domain. Each domain exhibits unique affinities for binding partners within the coagulation cascade, regulating Factor XI conversion to a serine protease. The disease was once called hemophilia C. Hemophilia C can be caused by reduced level of Factor XI protein in the blood or reduced catalytic activity of the active form of Factor XI, the Factor XIa. You can see here that among Ashkenazi Jews population, the so-called type 2 and type 3 mutations prevail. In 1 out of 450 Ashkenazi Jews, you are expected to find type 2 homozygous, type 3 homozygous, or type 2-3 compound heterozygous Factor XI deficiency. Factor XI deficiency can be classified as quantitative or qualitative based on the concordance or discordance of Factor XI antigen and the activity levels of Factor XI. Severe Factor XI deficiency is usually defined as an activity level less than 15 or 20 international units per deciliter, which is most commonly found in homozygous or compound heterozygous for the type 2 and 3 mutations. Heterozygous typically have Factor XI activity levels of 20 to 60 units per deciliter. Since Factor XI promotes thrombin generation and the activation of TAFI, thrombin activatable fibrinolysis inhibitor, patients suffer bleeding, especially when tissues with high fibrinolytic activity are injured. Having said that, let's look at some old paper addressing the frequency of bleeding in patients with major and minor Factor XI deficiency. You can see here that among patients with major deficiency, defined as level below 20 units per deciliter, about 72% of the patients reported in this series have had bleeding complication, especially around surgical procedures involving tissues with high fibrinolytic activity, whereas when factor XI activity was higher, patients with minor deficiency only had 27% of bleeding. And kindly note that now we consider that hemostatic levels of 30 to 40 units per deciliter are quite enough in order to lead surgeries safely. You do not necessarily have to have 60 units per deciliter or higher level, though it is still defined a minor deficiency of factor XI. This sounds very, very simple. However, bleeding in patients with severe XI deficiency following surgical procedure performed without prophylaxis clearly shows that the type of surgery is also very, very important. If we perform surgery in non-fibrinolytic sites without any support to patients with factor XI deficiency, you can see, and these are patients with severe deficiency, that only about 6% of those patients will bleed perioperatively. In tissues with high fibrinolytic activity, surgeries such as tonsillectomy, nose surgery, or prostatectomy would lead to about 60% bleeding. Oral surgery, like tooth extraction or gum surgery, can be complicated by bleeding in half of the patient with severe factor XI deficiency. Let's have a look at the clinical variation in factor XI deficiency and the impact of age and gender upon the bleeding symptoms. Newborns usually have lower than normal levels of factor XI activity. 30% activity of factor XI is considered normal for a newborn rather than XI deficiency. They may bleed following circumcision, any trauma or surgery. They never suffer thrombosis or non-trauma related bleeding episodes. With children, the factor XI levels reaches adult levels at about 6 months, so tonsillectomy, adenoidectomy, and trauma-related bleeds prevail as the causes for bleeding, especially in severe factor XI deficiency. Let's have a look at adults at reproductive age. Factor XI levels, unlike factor VIII or von Willebrand, are not affected by menstruation or pregnancy. Women may suffer abnormal uterine bleeds and even postpartum hemorrhage. Thrombosis may rarely complicate treatment by either factor XI concentrates or recombinant 7A, and we will address this issue later. When we move on to the elderly patients, factor XI levels are similar to younger adults. Prostatectomy, urogenital, and oral surgery may involve bleeding. There is a decreased incidence of venous thromboembolism among patients with factor XI deficiency, so it carries some antithrombotic protective effects, and data regarding protection against strokes or MI are still debatable in the population of XI deficiency. Among the Ashkenazi Jews with severe deficiency, patients with the genotype 3-3 with factor XI of about 10% had significantly fewer injury-related bleeding events than patients with the genotype 2-2 with factor XI under 1%. That this is a null mutation, the 2-2 homozygous mutation. Interestingly, some patients with XI levels below 15 units to deciliter do not experience bleeding, even during surgical procedures, while others with factor XI levels above 15 units per deciliter may exhibit severe surgery-related bleeding complications that require blood transfusion or revision surgery. So, despite all the nice table that I've shown you so far, factor XI levels and activity alone cannot accurately predict the bleeding risk in any patient. How do we diagnose factor XI deficiency? First of all, we have a history. bleeding, and therefore it is marked in red, or non-bleeding. Then we should address the bleeding and the surgical site, whether the surgical site is a site of abundant fibrinolysis or non-abundant fibrinolysis. In patients suspected of factor XI deficiency because of bleeding, because of family history, or because of bleeding around surgeries with abundant fibrinolysis, we perform the routine laboratory assays of coagulation. We take a blood count, we look at fibrinogen, PT and APTT that is usually prolonged. We should address von Willebrand panel as a potential reason for bleeding. And finally, we can look at factor XI levels. If the level is 0 to 1%, we should also look whether or not this patient has factor XI inhibitor, especially if he or she have previously been exposed to plasma or factor XI concentrates. For patients with 2 to 20%, or actually for 0 to 20%, we define major factor XI deficiency. For patients above 21%, we define minor factor XI deficiency. Global assays may assist us with the diagnosis of factor XI deficiency. We can address thrombin generation that would be lower than normal. We can look at TEG or ROTEM that are bedside tests. We can even have a look at clot structure and resistance to fibrinolysis, but these are usually performed for research purposes rather than for clinical daily care. Genetic testing, assessing the type of factor XI mutation, whether it is a null mutation or another mutation, is important. It is not usually performed, but for example, if we have patients with severe deficiency and with a null mutation, these patients would be highly prone for XI inhibitor if exposed to factor XI via treatment with plasma or XI concentrates. So planning surgery in a patient that we already know that is XI deficient is challenging. Why is that challenging? Because no bleeding score is available, because bleeding score is not applicable to patient with no prior surgery. There is difficulties in interpretation of the bleeding histories because there is usually no connection between factor XI level and the bleeding tendency, and there is absence of standardized laboratory methods for predicting bleeding risk in a given patient with factor XI deficiency. We should always consider the site and type of surgery, previous exposure to plasma or factor XI concentrate or gamma globulin, because patients may react even by anaphylaxis to repeated exposure, presence of an inhibitor, especially if it's a null mutation, presence of IgA deficiency, other combined hemostatic defect like comorbid von Willebrand that is quite common in the population, whether there is a thrombotic risk, atherosclerotic risk factors, or any thrombophilia, other gene environmental interactions such as sepsis, inflammation, or pregnancy, and if we are treating with plasma, the need for volume overload. There are guidelines for the diagnosis and management of rare coagulation disorders. And according to the UK guidelines, for minor bleeds or minor surgery in higher bleeding risk cases, and for all bleeds or surgery in low bleeding risk cases, in patients with XI deficiency, you should consider administration of tranexamic acid. For severe bleeds or major surgery in high bleeding risk cases, you should consider an initial dose of factor XI concentrate. This is always a treatment dilemma, how to secure hemostasis without increasing the risk of thrombosis. So tranexamic acid, an antifibrinolytic agent, and aminocaproic acid are used for minor procedures, tooth extraction, colonoscopy with biopsy, or other minor procedures in combination or with 7A or fresh frozen plasma or factor XI or tandem use. If we are looking at FFP, it's not applicable for patients with factor XI inhibitors. It's not applicable for patients with IgA deficiency. It enhances the risk of 11 inhibitor development, especially in null mutation patients. It may carry the risk of allergic reaction, volume overload, and transfusion-transmitted diseases. On the other hand, factor XI concentrate has a long half-life. It is efficient in predicting the increase of factor XI. It is heat inactivated, so there is viral safety. It's not applicable to patients with inhibitors or IgA deficiency either, and it may enhance the risk of inhibitor development in null mutation. But there is another important point. It is associated with thrombosis. Thrombosis was reported in BPL and LFB products, and mostly in elderly patients with pre-existing atherosclerotic risk. So we should definitely remember that. There is off-label use that is becoming quite common, and that's the use of a bypassing agent, recombinant activated factor VII, RF7A. It was initially developed for patients with severe factor XI and inhibitors, similarly to its use in patients with hemophilia A and B, an inhibitor. It is applicable to patients with inhibitor or IgA deficiency. Higher doses that are used in hemophilia may, of course, increase the risk of thrombosis. It has been used prior to spinal or epidural anesthesia, as well as cesarean section in women, of course, in small doses. The optimal dose of 7A to be given is not yet determined, but very small doses, 10 to 30 mic per kilo, should be adequate to correct the hemostatic defects. In hemophilia, we usually give doses of 90 mic per kilo per dose, and these small doses do not increase the thrombotic risk. Global assays may be used to safely monitor the dosing regimens, and to avoid the use of repeated doses of 7A, antifibrinolytic agents may be supplemented as well. Let's address a special interest group, and this will bring us closer to the case report that Dr. Schols is going to soon present to you in part 2. If we are looking at deliveries in women with severe factor XI deficiency, this was a series that was published from our own institute. Of course, we take care of a lot of Ashkenazi Jews. 82 women with severe factor XI deficiency conceived. Out of them, 62 conceived and 20 never conceived. We had a total of 146 vaginal deliveries and 18 cesarean sections. You can see that most of these events were not supplemented by FFP and also not supplemented by factor XI, as this concentrate was not available in Israel at the time. There was not a tendency for increased bleeding in these cases, despite the fact that they were not treated unless hexacapron, tranexamic acid only. So this is a very interesting study. Factor XI deficiency in women may present with abnormal uterine bleed or pregnancy-associated bleeding. For menorrhagia, antifibrinolytic therapy is usually the option. For pregnancy, no treatment is required, but you should remember that levels of factor XI should be determined before delivery and before any anesthetic procedure. Avoiding delivery at home in patients with severe factor XI deficiency goes without saying, and pregnancy can affect the sensitivity of global assays because of physiological hypercoagulability due to increased factor VIII, von Willebrand, and fibrinogen, and decreased level of coagulation inhibitors. On-demand fresh frozen plasma antifibrinolytic therapy could be supplied for vaginal delivery and cesarean section, not necessarily upfront. What about epidural or spinal anesthesia? Prophylactic therapy is required. Pregnancy causes engorgement of venous plexus in the epidural space, hence the risk of bleeding or injury is increased. The risk of spinal hematoma with compression of spinal cord in severe 11 deficiency is unpredictable, and therefore the options are tranexamic acid with FFP to correct APTT or 7A in a small dose, reported in a few cases and case series. With that, I will take you to Dr. Schols and to the next part of our presentation.
Thank you very much, Gili. So we have established a question of the state-of-the-art part. Our quiz question is, which statement best summarizes the bleeding phenotype of patients with a Factor XI deficiency? The first option is a baseline Factor XI level of less than 1 unit per deciliter correlates with the most severe bleeding phenotype, and it is recommended to start chronic prophylactic therapy in these patients. Or option B, a baseline Factor XI level of less than 10 units per deciliter correlates with the most severe bleeding phenotype, and these patients always require perioperative hemostatic therapy. Option C, Factor XI activity is not correlated with the severity of the bleeding phenotype. The personal medical bleeding history and type of surgery, the high risk versus the low risk bleeding, are far more important factors for choosing the right perioperative therapy. And the last option, Factor XI level is not correlated with the severity of the bleeding phenotype. Only in surgery in areas with a high fibrinolytic activity, treatment with hemostatic agents are warranted. The right answer of this question is option number C. Factor XI is not correlated with the severity of the bleeding phenotype. Instead, the personal medical history and the type of surgery are far more important factors for choosing the right perioperative therapy. Thank you very much for your attention.